Hi. So, this is going to be the heart failure series, and today we're going to discuss mechanical circulatory support, and the focus will be when, how, and for whom. Okay. So, just briefly about different kinds of mechanical circulatory supports. So, IABP is basically a catheter balloon device which inflates during diastole. Inflation of the balloon during diastole would push the blood towards the coronaries and would help in coronary perfusion, and it deflates during systole, which would decrease your afterload and cause LV unloading. This would decrease your end diastolic pressure and reduce the oxygen consumption. Let's move on to the second one, which is going to be ECMO. So, mainly discussing VA ECMO. What this does is artificially oxygenates the blood uh, by cannulating both the venous and the arterial circulation. So, takes the blood from your venous circulation, oxygenates it using this extracorporeal mechanism, and uh, pumps the blood back into the arterial system close to the aorta. So, this would be your left ventricle, and let's say the uh, cannulation sits around there in the ascending aorta, and this would pump all this artificially oxygenated blood into the circulation to the rest of the body. That it actually increases the afterload to the LV, as you can imagine, as we're pumping all this blood right next to the aortic valve. And this can decrease the amount that the AV valve is actually opening to the point that it may even stop opening and stops unloading the left side, which can be theoretically an issue. And then to circumvent this issue, there are different strategies that have been suggested, which are called unloading strategies. These can include if you use IBP along with a VA ECMO, or you use microaxial flow pumps such as impellers, and we'll go into more detail on this in a bit, or transseptal cannulation devices, just like the tandem heart. And I'll discuss this briefly as well. Evidence behind unloading strategies is actually pretty weak. Now, next, we look at the microaxial flow pumps. These are basically just literal pumps that suck in blood inside the LV cavity and pump it across the valve on the other side. So, this would be your aorta, and this is where the blood is coming out from. So, this is your inflow, and this would be the outflow. Two main types, impeller CP and impeller 5.5. This is a percutaneously implanted device. So you can implant this through your axillary artery, for example. And Impella 55 is a surgically implanted device. So this is actually less invasive, but also a shorter term use with this. Whereas Impella 55 you can use for a much longer time, and even for example to bridge to a VAD or a transplant. Another thing with Impella CP is that it only gives you about not more than 3.6 liters flow support, whereas with Impella 55 you can get up to 5.5 liter of flow support. Mechanistically, one more thing to mention is that as you can see from this diagram, that this is basically unloading the LV, and therefore in a similar fashion would reduce the end diastolic pressure and the oxygen consumption. However, it does require for the RV to have an adequate function and intact oxygenation from the lungs, because it of course needs that preload to be there in the LV, which is oxygenated for this device to have beneficial effect. Next, you can look at the tandem heart. This is the transeptal venous cannulation to femoral or iliac artery cannula. So this is your left atrium, this is your left ventricle. So this cannula would actually be here transeptally, sitting in your LA, and the artery cannula is sitting in the femoral or the iliac artery. So this is also basically unloading the left side of the heart in a patient with cardiogenic shock. You can imagine that that would be beneficial, and it's pumping that blood into the femoral or the iliac artery. This can give you up to 4 liters of support. Evidence behind this is only two small trials, which were about 20 years ago. And they did show some benefit, but now, due to the complexity of this device, it's mostly been replaced by the newer devices that we discussed. Let's look at some contraindications. So, most of these devices is contraindication if you have a severe aortic regurg, as it would keep pumping the same blood back and forth basically in such a patient. Another contraindication is aortic dissection, significant peripheral vascular disease, especially femoral, and then need caution with a patient who has had TAVR. Okay, now we're going to discuss three main types of cardiogenic shocks. Now, all cardiogenic shocks are not the same, and I want you to think about them as acute MI related cardiogenic shock, non-acute MI heart failure related cardiogenic shock, and three, post-arrest cardiogenic shock. Now, let's discuss each of these in more detail. So, for acute MI related cardiogenic shock, this can further be divided into three phenotypes. The most common one is actually post arrest hemodynamic instability, which is 50% of these patients. Second is LV predominant cardiogenic shock, which is in 40% of these patients. And then mechanical complications such as PST or papillary muscle rupture is only about 10% of these patients. It's helpful to think of acute MI related shocks according to these three categories uh, when you're thinking of various devices that you can use, because the data that we have available is kind of tailored to these phenotypes. It is important to identify patients with low flow states early on. Uh, Early modality you can quickly use at the bedside is echo, and you can look at the LVOT VTI, which, if it's less than 10 to 12 centimeters, will be associated with significantly reduced stroke volume and cardiac output, and can quickly give you an idea uh, of a patient in cardiogenic shock. Given the urgency to reperfuse these patients, right heart cath will usually be too time consuming. Another thing to remember is lactate uh, level in these patients is actually strongly correlated with worse outcomes. So, in terms of devices, let's see IABP first in these patients. Up until 2012, IBPs were used most often in this setting due to the intuitive benefit that we discussed, that in diastole part of the cardiac cycle, when the balloon will inflate, that will help with the coronary perfusion. However, when the data came out from the trial, which was the IBP shock 2 trial, which included 598 patients with acute MI related cardiogenic shocks. Mainly all were LV predominant failure shocks, uh, and it basically showed no improvement in 30-day, 1 year, or 6-year mortality. After the study came out, in Europe, the recommendation for IBP in this setting was downgraded to class 3 recommendation, which is harm, and the use there reduced significantly. There is still a class 2A recommendation in the mechanical complication phenotype. So in those settings, it can still be used. However, in the US, despite lack of evidence, actually IBP uh, continues to be used frequently. Uh, a second device I will look at is VA ECMO. In this setting, the largest trial was the ECLS shock trial, and this randomized 417 acute MI related cardiogenic shock patients, had all three phenotypes, and In this setting, also had lactate more than 3 millimoles per liter to be eligible. And again, this showed no benefit on all cause mortality at 30 days and had an increase bleeding complication and limb ischemia. There is also a meta-analysis that includes all 4 of the VA ECMO trials done so far, which also does not show a benefit. Third is the microaxial pumps. First, let's talk about the IMPRESS trial. This was mainly the post-arrest phenotype in 95% of these patients, and it looked at IBP versus Impella in these patients and basically showed no difference in 30-day or 6-month mortality. So again, a negative trial. Then there was the danger shock trial, which was a landmark article, included 360 patients, was predominantly LV failure, and this looked at Impella CP versus standard of care. So, just to give you an idea how difficult these trials of mechanical circulatory support are, this trial took 10 years to complete, um, but did show a benefit at 6-month mortality. It did have a higher complication rate with bleeding and limb ischemia, sepsis, CRRT, as well as longer hospital stays and ICU stays. So uh, that is a caveat to this study. There are also meta-analysis of 9 RCTs with MCS versus control that did not show a benefit in 6-month mortality. However, if you look at the LV predominant phenotype, temporary MCS use did show a benefit in mortality. Timing of the MCS in these patients, which is pre-cath versus post-cath, is a highly debated topic. In the Anchor trial, which was a prospective open label trial that looked at early intervention with Impella, which was pre PCI versus standard of care, which was basically you do the PCI, and if the patient then needs MCS support, you give them that support. And it looked at 30-day mortality. This was terminated early due to fertility. Thankfully, there is another trial, which is the Dan Shock trial, which is a large RCT currently undergoing. It's looking at Impella CP prior to PCI again. So hopefully you'll get some answers from that. And yeah, that was all about the acute MI related cardiogenic shock patients. Next, we will look at the heart failure related cardiogenic shock, which is the non acute MI. And this can be divided basically into 2 types, which is de novo heart failure, which is basically a new heart failure presenting straight away as a cardiogenic shock. And then there is acute on chronic decompensated heart failure, patient presenting as cardiogenic shock. And so the way that these two phenotypes may be different is that in de novo heart failure, the heart has not had time to remodel yet, and that is why it's theoretized that these patients may be more benefited from temporary MCS support compared to inotropes. Also, that the recovery is possibly more likely if you get them through this acute phase. But that being said, they also have a higher mortality compared to acute on chronic heart failure patients. And in this case, you often need to bridge them to a VAD or a heart transplant as an exit strategy. There's also a term called super responders, and the factors that are considered to be helpful in this include uh, normal RV function. Another marker for this can be a higher PAPI score, a higher pulmonary artery pressure. Now, looking at the evidence, there was the ALT shock trial, which was a uncontrolled small trial with only 24 patients with IBP support. Then there was a small RCT with 32 patients, which compared IBP to inotropes, and this also showed improved primary outcomes. The primary outcome they looked at was mixed venous oxygen saturation, and a secondary outcome also had increase in cardiac power output. Very recently, another RCT, which was actually the largest RCT yet to look at this question. The ALTROC 2 trial came out, which had 101 patients that randomized to IBP versus medical management with inotropes. And this actually showed no benefit or no difference at 60-day mortality. So then, um, again, this complicates the picture with one trial being showing some benefit and the bigger trial not showing benefit. So, okay, so now let's look at the last subtype, which is the post cardiac arrest cardiogenic shock patients. In this, basically, there's cardiac stunning, which is a well described phenomena. It can also be seen on cardiac MRI during the first 24 hours, which shows. Now, these patients are often comatose post arrest and hemodynamically unstable. They require intubations and subsequent sedation. Now, sedation also has a vasodilatory and cardiodepressant action. So these patients often require vasopressors after you start them on sedation. You can trend them with a lactate to figure out if the shock is worsening, and also if vasopressor requirements keep going up. That's a obvious indication of a worsening shock. But overall, if that is not the case, then these factors kind of argue against MCS requirement in these patients. Furthermore, many of these patients actually have high risk of death from hypoxic brain injury rather than a circulatory failure. Nevertheless, in refractory arrest and normothermic patients, Impella has been used with favorable outcomes. And in out of hospital arrests with hypothermia and patients requiring extracorporeal pulmonary resuscitation, VA ECMO is a modality that should be considered. Finally, some general considerations. For which patients do you want MCS to be considered? This is a complex shock team decision, but it's reasonable to consider MCS in your SCI stage D patients and Intermax profile 1 or 2. In a separate video, I will go over in detail what these stages and profiles are. And you want to intervene prior to irreversible end organ damage. In your heart failure, cardiogenic shock patients, if there's ongoing evidence of hypoperfusion despite inotropes or a patient failed inotropes, for example, due to persistent arrhythmias. One thing to remember is if your patient is not a candidate for heart replacement therapy, such as VAD or a transplant, these are patients who are not good candidates for MCS because they don't really have an exit strategy for them. In this case, palliative measures should be considered. More consideration, ask yourself if patient needs LV support, RV support, or a biventricular support. Does the patient have refractory hypoxemia? Are there anatomical considerations such as LV thrombus or dissections, like we talked about? How urgent is MCS support? Is the patient having ongoing cardiac arrest versus it's more of a elective procedure within the next 6 to 24 hours that's needed on an urgent basis? In your more severe shocks, some experts favor Impella 5.5 or VA ECMO over your Impella CP or IBP because they can provide more support. That's pretty much it for this lecture. Please leave any questions you have in the comments below, and I'll see you in the next video. Thank you.